So now I'm going to call on Robin Rawls, Director of Communications at Alabama Medicaid, and Cindy Crockett from HPE to get us started.
All right, welcome and thank you for that introduction and for your time today. In the next few minutes, we hope to give you information that you can apply immediately to the work you're doing in your respective practices. As Linda mentioned, questions may be asked via chat, and we will answer as many of them as we can at the end of today's presentation. If you have questions that are specific to your practice, our contact information will be at the end of the presentation, and we also have this information that we're sharing today on Medicaid's website under the Programs section, Medical Services and EPSDT. In addition to myself and Cindy Crockett, we have with us today Russell Green, who's Associate Director for the EPSDT program, and Beverly Churchwell, who is newly appointed Director of our Medical Services program, which includes not only EPSDT, but a number of other programs. Okay, go to the first slide. I'm going to start with a quick recap of the program, just in case there are some new folks among us. The genesis of the EPSDT program was in the 1960s when draftees reported for duty with unaddressed health problems that impaired their ability to serve. And so to address this, the concept of screening and treating health problems was incorporated into the Medicaid program. So the purpose of the EPSDT program is to find children with actual or potential health problems and to screen, diagnose, and treat those problems before they become permanent, lifelong disabilities. And that still is the mission today. The program also offers preventive health services to Medicaid-eligible children under 21 and includes an outreach component to ensure that families are aware of the value of preventive care and timely diagnosis and treatment. Next slide. Now, unlike private insurance programs, the EPSDT program is very unique in its range and its depth. One of the ways this is seen is through the offering of expanded periodic health exams with very explicit requirements. Another is the unparalleled coverage of diagnostic and treatment services through referral. And the important thing is that EPSDT is a central component of all state Medicaid programs, and as such is critical to improving the health of the nation's low-income children, and particularly so for those with special health care needs. Next slide. There are responsibilities for providers within the program. Some of these you are probably familiar with, but again, as a recap, screenings, the provider, of course, is the central person in making this program work. Medicaid requires that recipients that request screenings receive those within 120 and 180 days from the date the request was made. I think our folks do that, exceed that limit in many cases. This recipients are to be given priority by the provider when scheduling appointments. Recipients who request well-child checkups must be provided those examinations and assessments at the intervals that Medicaid has established. And then screening providers and primary medical providers receive a rescreen list every month. And the responsibility is that the provider should utilize that rescreen list to notify the recipients when the medical screening is due. And Cindy Crockett will talk more about using this we'll talk more about using this list later. Next slide. Our goal is to provide outreach services as an adjunct to the overall program. These are aimed at two groups. There's new recipients, and then all Medicaid eligible recipients who are under 21 who have not had a well-child screening in the last 12 months. This last group is notified by Medicaid via a letter twice a year, and we've placed a copy of this letter on the agency's website. It's certainly something you're welcome to modify and use if you want to do additional outreach. What we do is we identify the recipient and encourage them to make an appointment for an EPSDT screening. And the letter also has phone numbers for free resources such as the Parenting Assistant Line, Help Me Grow, and the Mental Health Services Referral Line. Next slide. The agency is required to track screening rates, and we do every year annually and report them to the federal government. In 2015, the overall rate for all ages was about 60%. But as you might expect, the best rate is for the younger children, and it peaks around ages 1 to 2 and drops off progressively with age after that. Adolescents are the least likely to come for preventive screenings and checkups. Next slide. We've received a number of questions related to RCOs, our regional care organizations, and the EPSDT program. As we get closer to the startup in October 1 of 2017, we'll be having information sessions, and the RCOs will be providing training as well. So it'll be important for you to work with your associations to be informed. What you should know right now is that all full benefit enrollees that are under 21 still will get EPSDT services as outlined in the RCO contract and federal law. And this includes services identified as the result of a comprehensive screening visit or an interperiodic screening, regardless of whether or not those services are ordinarily covered for other enrollees in the RCOs. And that is a specific provision in our draft RCO contract. Claims for non-covered services or that are provided as a result of an EPSDT referral that are not specified as covered services would be paid outside what we call the capitation rate, or will be paid fee for service. Next slide. Another important thing to remember is that once RCOs begin, overall care coordination for Medicaid recipients will be the responsibility of the regional care organizations. They will also be required to assess their members to see if care coordination is needed. The other thing to know is that the Health Home Program, which many of your patients may participate in, that will be incorporated into the RCOs. That is a condition of them being fully certified. So that program will continue to be offered by all RCOs. And last, providers will need to be aware that each RCO may have a different referral process, different PA process, and there may be differences in their requirements, which is allowed as long as they meet our contractual requirements. So you will need to expect differences, but in the end, the EPSDT program and its services is still an important and required component. Okay. Most of you know about EPSDT screenings, but it does bear repeating.
Screenings are important. You know this, a Medicaid eligible child can receive additional services if a problem has been identified during a screening. A referral is needed for EPSDT referred services, as well as a patient first referral if the recipient is patient first. And we all know that most children in the program are patient first. Some services, you need to remember, might require prior authorization. They will be covered, but prior authorization is required. The most important thing to keep in mind is that when screenings, particularly your interperiodic screenings, are done, this can help providers maximize your Medicaid benefits that are available to the patients. Typically, a child should never run out of their 14 office visits during a year. Next slide, please. This is the periodicity schedule, which most of you are familiar with. The thing that I really want to point out on this slide is if a child misses a screening, it is acceptable to bring the child in. For example, if they miss their 2-month screening and they come in at 3 months, it's okay to go on ahead and do that 2-month screening when they come in at 3 months. and get them caught up. Just try to bring them back in at 4 months and get them caught up. I like to explain to providers that recipients between birth and 1 year are allowed 6 screenings from birth to 12 months. They are allowed 3 screenings from between the age of 1 and 2, and then 3 and above is annual. If you keep that in mind, that'll kind of help keep you on track with doing the screenings. Next slide, please. There are several different types of screenings. The initial screening is the first time a screening is done on a Medicaid recipient. Your periodic screenings are performed according to the periodicity schedule. Your intraperiodics are problem-focused and are done on an as-needed basis. And we're going to touch on that several times throughout the presentation today to make sure you understand when an intraperiodic screening should be done. A vision screening should be done. We're going to go over some of the components later. Hearing, an emotional and behavioral assessment, as well as, a dental. Just what's the difference in a periodic and an interperiodic? Your periodic screenings include a comprehensive history, an unplugged physical, your developmental, lab, immunization, and checkup that follow the periodicity schedule. Your interperiodic are new screenings between your periodic screenings. They're always problem-focused to identify new problems between screenings. Next slide. Your required documentation for your initial and periodic. It's important to know that having complete documentation of screenings is critical to accurate payment and helps prevent recoupments from a post-payment review standpoint. The elements that are noted above are outlined in the billing manual in Appendix A. Some providers like to use our optional EPSDT Child Mental Health Record Form 172 to make sure all the required elements are covered in the visit. Some providers use a rubber stamp or something similar to facilitate accurate documentation. All this information is available on the agency's website, on the EPSDT page, or in our forms library in the resource section. Just one other note, all screening providers must maintain complete records for 3 years plus the current year. And that's kind of the standard for anything Medicaid related. Next slide, please. The primary types of screenings, I've already discussed this, just have it on the slide just for you to review. I just want to point out the difference in a periodic and an interperiodic is your interperiodics are always problem focused. Next slide, please. There are some 4 other specific types of screenings. The first is vision, and the criteria for actually billing your vision screening is listed on this slide. I won't read over it with you, but just want you to make notes as needed. Next slide, please. Your hearing screening, again, it's history plus subjective. Won't go over the information with you, but it is listed on this slide. Next slide, dental. Again, this is history plus subjective. It is included in the EPSDT screening itself. For the longest time, and I remember back years ago, a lot of our Medicaid children didn't receive good oral health. It didn't get a lot of attention. But with the addition of the First Look program, we've had great success with helping children get some of their care that they need. It's really made a big difference in children age 0 through 3. We have a list of dental providers on our Medicaid website. You can find that under programs, medical services, and dental. Next slide, please. The emotional and behavioral assessment is something that we want to talk to you about a little more today. The emotional and behavioral assessment is very much a part of the EPSDT screening program. The procedure code 96127 may be billed for children aged 3 through 20. Assessments must be ordered and signed by a physician or a non-physician practitioner, and these may also be incorporated into a screening. We were discussing among ourselves before the presentation started today that if you have a child that comes in during their EPSDT screening and you perform an emotional and behavioral assessment and you find a problem during this assessment that requires care, you should include that diagnosis in your EPSDT screening so that you can refer the child out as needed. If they come in and you do an emotional and behavioral assessment and it's outside of the periodicity schedule and you find a problem, then you should do an interperiodic screening at that time and include the problem you found during the emotional and behavioral assessment in with your interperiodic screening so that the child can be referred out as needed. Next slide, please. Bright Futures Guidelines for Health Supervision of Infants, Children, and Adolescents emphasizes that mental health screening does not provide a diagnosis for mental health disorder, but does allow the screening provider to perform an important assessment using existing screening tools, such as those for maternal depression, developmental delays, or other conditions such as PSC, or the more brief PSC 17, which can be filled out by the parent while in the waiting room. Next slide, please. At this juncture, we want to take just a few minutes to discuss behavioral health in the context of the EPSDT program. Here, like in other areas, the focus is on prevention when possible, timely diagnosis, and interventions when appropriate. Next slide, please. Childhood is where mental health and behavioral issues start. Here, the EPSDT program can have a major impact when screenings are performed at appropriate times. Here are some things to think about from the Bright Futures Guidelines for Health Supervisions of Infants, Children, and Adolescents. Half of all lifetime cases of mental illness begin at 14 years of age. 21% of U.S. children, adolescents, 9 to 17 years old have diagnosable mental health disorders that cause some impairment. Fewer than 1 out of 5 youth receive the needed treatment. A high rate of psychiatric disorders, 66% in boys and 75% in girls, exist among youth and juvenile justice facilities. 50% of the kids were addicted or had abused substances. The opportunity to make a difference in the lives of these children is while they are young. Next slide, please. Behavioral and mental health issues are widespread among children, and particularly so among Medicaid eligible children who may be more impacted by family, social, and other family risk factors. And this, again, is according to Bright Futures Guidelines for Health Supervision of Infants, Children, and Adolescents. Risk factors, of course, include genetic factors and chronic illness. But by definition, Medicaid eligible children are disproportionately impacted by poverty and may also suffer ill effects of homelessness, domestic violence, or violence in general, and lack of stability in the home. Many children have been impacted by parental substance abuse, family breakup or instability, or simply lack of parental ability in terms of parenting knowledge and skills. And then many children have social skill defects or undiagnosed learning disabilities or other issues impacting their ability to learn and succeed in school. Next slide, please. Bright Futures Guidelines for Health Supervision of Infants, Children, and Adolescents suggest that there are some situations that benefit from a referral to a mental health professional. Here, performing a periodic or interperiodic screening will be more important to maximize coverage of services. There are a number of situations that providers may want to consider referring patients. They include emotional dysfunction evident in more than one of 3 critical areas of a child or an adolescent's life. This may include home, school, or peers. Patient is acutely suicidal or has signs of psychosis. Diagnosis uncertainty exists. Patient has not responded to treatment. A parent requests a referral. An adolescent's behavior creates discomfort for personal care professional, meaning an adolescent is acting out or seductive behaviors. Parent or family has social relationship with treating healthcare professional. Next slide. If we can just go to the next slide. In order to give a referral for services identified during a screening, providers must complete the Form 362 completely. It must be completed by the provider that performed the screening, and it must include the screening date that the problem or problems were identified and the reason for a referral. There are a couple of points I want to mention here. For physicians that are in the same group or practice that have one common medical record, a referral is not required as long as all documentation by physicians in that group for a recipient is included in that one common medical record. For referrals to specialists outside of the group, a written referral is required. Next slide, please. If no common medical record is shared within the same group or practice, written referrals are needed within that practice. Referrals to specialists or other physicians outside of the group do have to have both a EPSDT referral and patient first. And I mentioned earlier that most recipients who are EPSDT eligible are also patient first. Next slide, please. It is the responsibility of the screening provider to make referrals, complete the necessary forms. I just want to stress to providers, you may not put signature on file on the referral form. That is not accepted. That form has to actually be signed. Consulting providers should contact the screening provider for approval of any and all referrals unless that screening provider has gave okay for other referrals out as needed. Next slide, please. PMP should make sure that EPSDT screening date is on the form. If it is not, that entire referral form is invalid. Just to repeat some of the responsibilities of the PMP, you should be completing the EPSDT referral form for your service, and the referral number is the NPI of the PMP, and it must also be noted on the claim form when the claim is filed. Next slide. If a recipient is referred to a specialist in the ER, for example, a broken bone, they must go back to the PMP for the appropriate EPSDT patient first referral prior to seeing a specialist. EPSDT referred services for inpatient stays will not count against the physician inpatient 16 limit as long as services are billed appropriately. That means as long as they are billed as EPSDT referred. Next slide. We have several resources for providers for claim submission, prior authorization, checking eligibility. We have our provider electronic solution software that allows providers to submit information to us in batch mode. We also have our Medicaid interactive web portal, and we also have the automated voice response system. All ways for you to check eligibility, file your claims, get the help that you need. All of those are available free of charge. Next slide. Please make sure that you're downloading and using your periodic rescreen list. It's updated monthly. It's available for download through the web portal and helps you perform outreach to provide necessary care for your EPSDT eligible recipients. The next two slides actually show you how to download the report. You'll go to the next slide. You log on to the Medicaid web portal, go to Trade Files and Download. Next slide, please. You have a drop-down menu of available reports under transaction type. You should select the periodic rescreen list, and the necessary information will display. Next slide. To participate in the EPSDT program, providers must complete the EPSDT agreement form and send it in to provider enrollment. We've talked about the EPSDT referral form several times already today, and the next couple of slides have a copy of the form, and the required fields are highlighted in red. The Form 172 is optional for the program, but it can be useful to providers. The next two slides, I'd like for y'all to reference this back in your office. It's also available on the Medicaid website, and it just lets you know every field that is required to complete an EPSDT referral form. If the fields are not required or not completed, then the form is considered invalid. Let's go ahead to billing. Y'all already know this, but providers should always verify eligibility prior to rendering any service to Medicaid recipients. I won't go over all the ways for you to verify eligibility, but verifying eligibility will eliminate a lot of denials and a lot of problems down the road. Next slide. This slide just lists the EPSDT screening codes. Not going to read over them with you, but we have listed them here for your review. Next slide. We've talked a lot about the different types of screenings, but I just want to make sure that I stress to you, interperiodic screenings are used to identify new undiagnosed problems between screenings. They should never be billed in place of an office visit if benefit limits have been exceeded. What you should be doing is, as you identify new problems between screenings, you should bill an interperiodic screening, and then when a child comes back in for follow-up care, you should be billing the appropriate level of office visit and marking that as EPSDT referred. One of the number one problems that I see is, instead of providers billing EPSDT referred services, they bill interperiodic, and that is not the correct way to bill. Interperiodic is new undiagnosed problems between screenings. When they come back for any follow-up care to any screening, you bill the appropriate level of office visit and indicate EPSDT referred. Billing as EPSDT referred is required to exempt from benefit limits. Next slide, please.
This is the website, and this is where a lot of resources are available. You'll find it under Programs, Medical Services, and EPSDT. Now go to the next one.
All right, next slide. I have our contact information listed for you here. I know a lot of you know how to get in touch with us already. Feel free to contact us with any questions that you may have.